Hey everyone, my name is Christian Saliba and I'm a first-year pediatric surgery fellow at Cardinal Glennon Children's Hospital. It is my honor to present my first CB clip, which is a newborn baby with bowel obstruction. So our kid is 2 days old. His mom's pregnancy, pretty much uncomplicated except for preeclampsia during her last week of gestation. Day of life 1 past meconium, day of life 2 biliary emesis, belly is distended, however it's non-tender and soft, plain films on the right showing distended bowel loops, contrast enema we're going to talk in a bit. Initially, our differential diagnosis should be intestinal atresia, meconium ileus, meconium plug, small left colon, and Hirschsprung's disease. Contrast enema should answer these following questions. Is there a microcolon? Is the colon patent? Can you reflux contrast back into the distended bowel loops? The contrast enema in our case showed no microcolon, a patent colon. However, we were unable to reflux the contrast back. First clinical principles to talk about are the passage of meconium does not rule out Hirschsprung's disease, same as a contrast enema cannot rule it out. Also keep an eye on subtle radiographic findings. Example here we have a question mark colon on our contrast enema. During our expiratory laparotomy, we found a resistance zone at the level of the terminal ileum, 15 cm from the ileocecal valve. We resected some of the small bowels there and did a terminal ileostomy. The resected specimen came back negative for ganglion cells, so this kid has total colonic aganglionosis reaching the terminal ileum. We then did a formal staging procedure where we only found ganglion cells at the level of the jejunum, 35 centimeters from the ligament of Treitz. We also did a gastric biopsy to rule out total digestive aganglionosis. Fortunately, we did find ganglion cells there. So eventually, we just put in a G-tube and we are optimizing his nutrition. And eventually, in a couple of months, we'll be doing a small bowel pull-through as the definitive management. Final clinical principle to talk about is that total colonic aganglionosis can have variable presentations and should always be considered as part of our differential diagnosis when we have an atypical neonatal bowel obstruction. I thank you so much for this and see you next time. Bye-bye.